to 2022 emphasizes such primary care dependent themes as responsive health systems, holistic approaches to health and wellness, and research in equity and health. Primary care made headlines when the former Secretary of Health and her team were sent by the President to Cuba, a country known for its successful primary care model, to study their health system. Today, we will be hearing about our own situation and innovations from our own experts, and that includes everyone present here, since we all have a role to play. Amid the glamour and prestige of subspecialized and sometimes commercialized medicine, the country's primary care providers are heroes in the sincerest yet most unsung ways, especially in our nation's most resource-constrained areas, which need them the most. We owe it to them to put our minds to our task today of clarifying and elevating their continued professional development so that they may continue to serve their fellow Filipinos, derive meaning from their calling, and work in concert with one another. They must function as primary care teams, integrated, competent, resilient, and inspired. While this vision has always been among the aspirations and achievements of health workforce development in the country, in these changing times of triple burden of disease, widening inequality, and fierce competition from international and other lucrative markets, we must continually reevaluate and improve the way we hone our skills, treat the sick, and safeguard health. A necessary first step is to have a common understanding of what exactly our training programs seek to develop. What are the goals of training in primary care that we need the most? With your help, I am confident we'll find answers and lead our health system forward. Again, I would like to welcome you all on today's stakeholders meeting on training objectives for primary care. Thank you, and we look forward to a fruitful discussion this morning. So I go to my next task, which is to give you an overview of today's meeting. So I have the honor to present to you the objectives of this particular activity. This is a project under the Health Sciences Division, which I currently chair, and is led by academician Antonio Danz. We have a... Oh, anyway. So, I think, especially these past few days and weeks, the healthcare has been at the center of news. But more than that, I think what we should reevaluate is how the Filipinos at the primary care level will benefit from a healthcare system as devolved and as diverse as it is in the Philippines. It is a Herculean task, I think, that we'll be going to do, but fortunately, we can start somewhere. And this has been initially started by a group of like-minded people led by academician Antonio Danz to look at what we can do as far as primary care is concerned. It's not just looking at what the problems are, but also looking at how we can improve the current setup. He will subsequently present to you some of their initial studies and their experiences in some communities in the Philippines, which they hope to replicate in other communities as well in the country. So all of us here come from different perspectives, but all with the common aim of improving healthcare delivery in the country. So I hope you will agree with me that when we talk of healthcare, it all boils down to the ordinary Filipino in some far-flung area, or maybe in some place in a city, in a province in the Philippines. That is what matters. And we will be having an introduction to this concept of revisiting our primary healthcare in the Philippines through the lens of our researchers led by academician Antonio Dan. So I will not prolong the discussions. In behalf again of the National Academy of Science and Technology, our President, Academician William Padulina, and the Health Science Division and the whole membership, we'd like to thank you for coming to this meeting, and we all look forward to your inputs, suggestions, comments, so that we can improve on this and hopefully, ultimately, this will benefit the majority of Filipinos. Again, thank you very much at magandang umaga po sa inyong lahat.
Thank you very much, Dr. Montoya. And certainly, in research, one of the things that we're often told is it's the dissemination, it's a translation into engagement with society. And one of our key partners has always been the DOH, and I guess we got someone who exemplifies that kind of reaching out to society, what our work means, is someone familiar to us from his media appearances, but I'd like to introduce, perhaps in a more technical but less than 3-page now, if I can, manner, is Dr. Enrique Tayag. So our next speaker is to give a talk on primary care as the flagship strategy for universal healthcare in the Philippines. Dr. Enrique Tayag. He is currently Assistant Secretary at the DOH and Concurrent Director at the Bureau of Local Health Systems Development. His stellar career in public health, particularly epidemiology, health systems, and universal health care. Multi-awarded public health figure, familiar to all of us from his interviews in media and public health issues, which have prepared him well in becoming the official spokesperson of the DOH since 2005. More recently, he attracted public awe and amazement as he continues to lead the government's efforts to combat NCDs, and this is on top of a strong history of also containing outbreaks and epidemics such as H1N1 in the country. So now combating non-communicable diseases by inspiring the country to embrace the healthy lifestyle through his routine dance exercises that have become viral in social media. May I call on DOH Assistant Secretary Tayag to deliver his message.
Good morning, everyone.
Good morning.
I'd like to greet several personalities, of course. While he's not here, Academician William Padulina. How about a round of applause for the President of the National Academy of Science and Technology, Academician, my friend Jimmy Montoya, and Academician Tony Dance, and all the others who are here. Good morning.
Good morning.
I don't have a PowerPoint presentation. I don't have a speech to read. And I don't have a dance. But we have Tony Dance. And you died. Okay. So I've been given 15 minutes for this topic. Primary care, flagship strategy for universal health care in the Philippines. I hope that we have a common understanding about primary care, but nowadays, primary health care and primary care are fused or confused. Now, when I looked at the program, it's my suspicion that this is about primary health care, or if it is actually only on first contact, a family medicine-like care, individual care, then it's primary care. But nevertheless, I'd like to share with you the Universal Health Care Roadmap under Secretary Duque III. Everybody remembers Secretary Vial's Philippine Health Agenda. And Dr. Montoya mentioned a while ago that it has 3 guarantees: the service packages that will have to be provided, improving its access using the life course approach From womb to? Hindi ho kami St. Peter's. Yun ang sinasabi ko. Sige. From womb to, sige, end of life care. Sige. Huwag naman yung to. Okay. And the second one is a functional service delivery network. And the third one is social health insurance. Okay. Now you want to ask, are we changing this with Secretary Duque's new directions? Okay. Suddenly, for the DOH, it's Formula 1 Plus. Okay. Now, the Philippine Health Agenda, the 3 guarantees, stays because it was incorporated in the Philippine Development Plan. So, end of argument. Okay. The Formula 1 Plus allows us to examine the health situation now and design a roadmap for the next several years until 2022 and perhaps 2040. So what do we have here? Every year, around 10 women die during their pregnancy or childbirth. 1 out of 3 children are stunted. 30 new HIV infections are reported every day. Around 80,000 die from complications of smoking, or maybe more. The most current TB prevalence study revealed that 1 million Filipinos have tuberculosis. And so on and so forth. And we're facing a fragmented health system so that health outcomes are in varying levels of magnitude. So there are disparities. And let's face it, for many years now and in the future, we have been focused on acute care, not on chronic care. The chronic diseases known as non-communicable diseases, lifestyle diseases, or degenerative diseases, interchangeable terms, are the leading causes of death. Or are they? Because PSA, that's the Philippine Statistics Authority, will report that 1/3 of deaths in the country do not have death certificates. So how else can we plan if we don't know the leading causes of death? I remember 15 years ago when I was vetting on the leading causes of death, the number 8 leading cause of death was, you want to know? The number 8 leading cause of death was stop breathing. Please don't stop breathing. And so we had to train doctors how to fill out their death certificates. And then another 8% do not have birth certificates. And then PSA just announced increased fees for these certificates. Now, what's the roadmap with the Formula 1? It focuses on financing governance, the pillars of the health system. You're familiar with those. But there were several discussions, and this is a preview, your privilege. The first strategic focus is the institutionalization of functional service delivery networks at each province all over the country. The second one is for the Department of Health to lead a whole of society coordination or collaboration so that we can meet our targets, whether they're SDN targets, Philippine Development Plan targets, or even those included in the National Objectives for Health. So let's look at the service delivery network. What do we mean? It's a network of organizations providing information services. But we have to change the mindset. Because in this country, ladies and gentlemen, when we say providing services, services are only provided if there's the infrastructure, there's the equipment, there's medicine, there's health human resource, and all those that we have to mention so that we can provide the services. We have to change the mindset. So in our issuances, we actually use these words. Making arrangements so that services will be provided. Can you repeat that? Making arrangements so that services will be provided. Okay. Just imagine yourself going to Green Hills because you want a new smartphone case. You approach a stall and alas, the sales lady tells you, we don't have that color. And so you're disappointed and you look at the rows of stalls. This will take me more than an hour to find this particular case. But then she offers you a seat. In 3 minutes, she's back with your preferred color of the case. What happened? She made arrangements. So basically, when we say service delivery network, it works like this. People here, can you imagine this is a barangay health station? Just imagine, okay? And this is a health center, and possibly another health center. Then there's a district hospital, a provincial hospital, a DOH retained hospital, a private hospital, that's Philippine General Hospital, and there's the Philippine Heart Center. What happens in the service delivery network? A patient at first contact with any of those I mentioned. So we do not distinguish between private and the public sector. All those providing services should be in the network. So say this is the network for a province. I'm a patient, my first contact with the health center. I'm not the client or patient of this health center. I'm the patient of the network. That's a paradigm shift. That means the health center has to make arrangements so that the services I need, I will get them. It may be not with the health center. It would be possibly with the barangay health station going back. Or escalating to a district hospital or perhaps the Philippine General Hospital. The other way around, the supply side. The health workers, which is the focus for this particular meeting. Those in the Philippine General, what's happening? It should not be, okay? And then the disease-based approaches limits the understanding of health providers of what's wrong with the patient. Immediately, the question is, what is wrong with the patient and what can I give the patient? So there's a pill for every ill, okay? And that's putting the mindset differently, when in fact, what we should ask is, why does the patient have these symptoms, these signs? Okay. This is important because for many years, because of advances in infectious diseases, and infectious diseases will be paired with a particular antibiotic. It's a one-to-one, but it has changed. We are beset with chronic diseases. It has multifactorial causes. It presents in different ways, varying from person to person, or even in a time spectrum. And so therefore, when we see a patient and box in that patient to a particular disease, then you also have potential problems with clinical practice guidelines. The clinical practice guidelines works with certain diseases, but it may not work now that we are refocusing on people-centered care. This will be difficult. The existing curriculum does not focus on this yet, the medicine of why. In the United States, they call this the functional medicine. We're still in the conventional approach to medicine. These approaches may work or may not work, but one thing is sure, the service delivery network is an opportunity for the health system to cure the fragmentation and the disparities in health outcomes. The health system now is likened to the MRT, wherein suddenly the train stops and all passengers have to get off. That cannot happen in the health system. But slowly we are seeing signs that they are, and we are facing challenges because in the horizon, federalism may have impact on the current health systems. So the Department of Health and with your help are rushing to put in place the basics and fundamentals of a service delivery network. The service delivery networks allows us mutual agreements so that even new technology, as in virtual medicine, can be employed. Imagine a barangay in a geographically isolated, disadvantageous area. There are no doctor takers. They don't want to be deployed there. But they have the facility. They can connect with the Philippine General Hospital in real time and actually provide assistance, support for the care of a particular patient. So I would like to go on, but the message is clear. We have disparities in health outcomes. The health system is fragmented. We have analyzed so many scenarios. It's the service delivery network that will change the landscape of the health system. Ladies and gentlemen, we have to believe, because only in believing that information becomes of great value. Thank you so much and good morning.
Thank you very much, Dr. Tayag. May we call on Academician Jaime Montoya and Academician Miguel Dance to present our certificate and token of appreciation to Assistant Secretary Tayag.
Then I will dance now. Music. Thank you so much. I'll stay the whole morning.
Round of applause again. Thank you very much. We're very honored with your presence, sir. And thank you for the, the systemic overview, to which I think our next speaker is someone who can really speak to that. So Dr. Tayag mentioned the SDNs, and the SDNs as a key. In terms of what we're going to think about the training, in terms of training today, that means teams. And teams working together means putting on our HRH, or Health Human Resources lens or hat. And someone who can really bridge, I think, the technicalities of HRH with the ideals and tenets of primary healthcare that Dr. Tayag also spoke about is our next speaker. To discuss on the health workforce development challenges in Philippine primary care is Dr. Feli Marilyn E. Lorenzo, currently Chair of the Technical Committee on Nursing Education at the Commission on Higher Education, or CHED. Dr. Lorenzo is someone with years of experience. And when she speaks of primary healthcare, it's from years honed and growing up as a professional in the primary healthcare years, and as those transition to our current climate now of thinking about HRH. Years of studying it, teaching it at the College of Public Health, among other areas. She has a strong focus on HRH and has worked as part of the Universal Healthcare Study Group. Please welcome Dr. Feli Marilyn E. Lorenzo.
Morning. Morning. Glad to see all of you this morning, and thank you for Dr. Tony Lance and his team for wanting to tackle a very complex but important topic, which is health workforce. And I'm glad to see that all of you will be engaged in a workshop later on to determine what may be the solutions that we can come up with in improving professional workforce development. We will actually be delving on the challenges of primary primary care workforce. But I'd like to start off with the rationale for health workforce development, so that we can see where we're coming from when we talk about the challenges. Secondly, we'll go into workforce needs, and then attack the workforce challenges that we hope you will be thinking about as you determine what directions workforce development should take in the Philippines in accordance with populating primary care. And I'd like to leave some HRH thoughts with you at the end. So when we talk about the rationale for HRH development, why do we need to develop health human resources? And this comes from the work of Professors Oskan and Hornby as they did their work in Malawi. We have taken this as the underlying tenet in developing the HRH master plan for the Department of Health, first in 2005 and then again updated in 2014. So we believe that the Philippine health services should have the right number of people at the right place, at the right time, with the right skills, with the right motivation and attitudes, at the right cost, doing the right work, and under the right work conditions. The last one, the under the right work conditions, we added to the work of Doctors Hornby and Oskan. So if you look at their work, you might just see the 8 R's, and they call this the 8 R's. And for those of us in HR work, we remind ourselves that these are the 9 R's that we must actually fulfill in order to have a very effective workforce. So, very quickly, I'd like you to look at the primary care workforce needs. So, based on the 9 R's, we need 3 very important things if we group all of that. The first one is adequate number. So that goes without saying, and this is a problem all over the world. And when you say adequate number, we do not mean a surplus. We do also not mean a shortage. It just has to be the right number. And what is that? We should have enough workers to focus on specific programs or tasks. And more than just having the adequate number at the national level, they must be equitably distributed. So the right number should be on the aggregate and as well as on the ground at the primary care level. Second, health workers need to have appropriate skills. And this refers to relevant and effective pre-service education and continuous education and lifelong learning. So as you know, the Philippines is one of the recognized producers of all cadres of health workers. Right now, we produce 22 cadres of health workers in the Philippines at the professional level, including the technology cadres like the RadTech and the, well, of course, the MedTech has been with us for a long time, but there are new technology levels, and as the latter type of education is being encouraged at CHED, there are more sub-professional categories that are very important that are being developed right now. When we talk about relevant and effective pre-service education and continuous education, we're talking about linking in-service education with professional training or the pre-service training. So first of all, the pre-service training has to be relevant and it has to be effective. And I'm glad that Dean Destura will speak after me because this is a program that has been close to our hearts and something that we have helped develop for over 30 years now. And so we must be clear on what we want to produce. Are we producing primary care workers after they graduate from the BS degrees? Or are we producing specialists? Are we producing workers for the public sector alone, or are we producing health workers that can breach both public and private sectors, but work at the primary care level? There are certain questions we have not adequately answered as a team. And so some categories prepare specialists, some categories prepare primary care workers, and they don't meet somehow in the field where it matters most. A third need that's very important is, I forgot, the appropriate skills. One more thing there is that we all know that in health sciences, technology rapidly changes. And so what the knowledge and the skills that you graduated with will be passé by sometimes as early as 3 years or 5 years after graduation. And the health system right now does not really take care in ensuring that the skills that our health workers have are still up to date, cutting edge, with the needs and relevant and responsive to the needs of the population. And so when we talk about appropriate skills, that should all come in there. Third, we need to have adequate support for the health workforce needs. And this has been a clarion call for many years now. And why do we need adequate support? So workforce is highly motivated, and when they are highly motivated, they will ensure patient safety, quality of care, and very importantly these days, we talk about delightful patient experience. For example, to follow the example of Dr. Tayag, like, why has TB risen in spite of the fact that we now have the chemotherapy that is known to be very effective? On the ground, when we were evaluating the TB programs and the work of the primary care workers, it's because they do not want to go back to the health workers because the health workers scold them for not taking their drugs, or the health workers scold them for being late for their appointments, or they get scolded also for being poor and not having enough food to eat when their weight does not increase. So the delightful patient experience, we think, should only be for the private sector. I do not think so. And I think if we will improve finally healthcare outcomes, we need to ensure delightful patient experience. But how can you get delightful patient experience with grumpy health workers? So, the adequate support will include policies, work environment, and financing. We also need, and that will lead, if all of these three are met, these three needs are met, that will lead to hopefully responsive and engaged health workforce. So this is the other thing. We have a lot of health workers, but they're not engaged. If you see them in the health centers and many times even in the hospitals, the health workers' attention is elsewhere than on the patient. And I've seen this a number of times. I mean, they're in front of the patient, but they talk about their social activities. For nurses, they talk about who is recruiting them and what next country they will be going to. They're not engaged. No? But if you go to other countries, like when we were observing the Japanese nurses who were also too few and they were trying to recruit Filipino nurses, you could see that there was nothing else that they were working on except their patients, and they were fully taking care of their patients, giving them baths and all that. So this will be the outcomes of meeting the workforce needs. Okay, now let's go to the challenges quickly. No? So the first challenge in keeping with the rationale and the needs, first is we have currently inadequate numbers of health workforce at the primary care level, and they are also inadequately distributed. I think we all know this, no? But the analysis of this situation will lead to the realization of certain things. One, right now, we have an antiquated HRH to population ratio. And this has been breached many years ago, and we need to reanalyze this. So for example, we have in our policies, in DOH policies, there should be one doctor, one nurse, one dentist to 20,000 population, and one midwife to 5,000 population, and no ratios for all the other categories. So that's why you do not see PTs in the plantilla positions of many hospitals in the rural areas. So communities have now reached 50,000 population, and yet they only are entitled to one doctor because the support is not forthcoming. Distribution of health workers is very heavily influenced by the health labor market. The incentives and disincentives are actually being provided by the health labor market. So where the salaries are higher, the health workers will go. And that's why we now see two types of migration in migration. The shift from private to public institutions because the government is a better employer right now. And we also see a shift from rural to metro areas because the incentives other than monetary is there. There is also ineffective multitasking. The default system makes it difficult to standardize the workforce. We have the personal service cap, a policy problem. We have health professional silos and deployment and retention. I'll just go through this quickly in the interest of time, and so we can discuss this later. The second set of challenges is problematic skill mix, weak teamwork, and demotivated workforce. So we have uncoordinated professional practice laws. We lack interprofessional training and socialization. So what we found in SHS that Dr. Distura will tell you about is that when you train them under one curriculum, they become friends, they learn how to work together. So in the field, they have better coordination and better camaraderie. There is also a lack of skills updating. We have to consider training vis-a-vis development. Most of the things that we do right now in the health system is just training. And training is only for a specific set of skills, like learning how to use PowerPoint. But you cannot train leaders. You have to develop them. You cannot train advocates and change agents. But you have to develop them over time. There is also severe multitasking, and this leads to burnout. Some cadres are not part of the team, and this affects essential services. So like dentists now are optional. So dentists, not like before, were part of the basic healthcare system. And here, I put in unappreciated, unrecognized, and uncompensated primary healthcare work. They are expected to go to do home visits, but there is not enough budget for travel allowance. And they're not, in the past, the RHUs gave them the old army jeeps to bring them around for case finding. But now, there are very few enlightened governments that will give motorcycles to their midwives, which is quite energizing. Thirdly and lastly, we have problematic work and work environment. Job descriptions are not updated, and the job analysis has not been done regularly. Work environment is not healthy nor safe for health workers, so there are a lot of ergonomic considerations that are not followed. Sometimes it's just the light even that's not provided well in the RHUs or even in the hospitals. Then, how can they do their work if they have inadequate medicines, equipment, and supplies? As you know, NPGH is not exempt from this. In order for us to give care to our patients, we have to shell money out of our pockets to provide these things which the system should be providing. Okay. So, given all of that, I had one slide that I wanted to add, but there are systems problems also that will be the foundation of all of that. I was just reminded when Dr. Tayag was talking about it. And the system problem is that HR is always subsumed under some other pillar of the health system. And this is something that we have been advocating for. Human resources should be seen as a separate pillar that contributes very vitally to the whole health system. If it is not given its proper place and attention, then we will continue to suffer what we have been suffering for decades. So I'd like to leave with you Chinese proverbs and some sayings. And in the Chinese proverbs, it said, if you want to prepare for 1 year, grow wheat or grain or food. If you want to prepare for 10 years, grow trees. But if you want to prepare for 100 years, you have to grow people and develop them. Also, one of my idols, Dr. Mahler, who gave the clarion call for health for all in the 70s, said that PHC starts with people, their health problems, and their active involvement in solving those problems. And we have to challenge them to do that. The next Director General of WHO also recognized the importance of HR, and he said, to ensure, and this is Dr. Lee, to ensure access to a motivated, skilled, and supported health worker by every person in every village, everywhere, is WHO's task. And finally, Dr. Margaret Chan said, you cannot deliver health care if the staff you trained at home are working abroad. We have to retain them and we have to keep them. And lastly, in the 26th Working Together for Health report, this was already published. But we keep forgetting about this, and I will just read them to you to end our session. Health workers save lives. Support them, educate them, love them. Don't leave them, or they leave you. That's not a threat, that's not a promise, it's already a fact of life. Thank you.
Thank you, Dr. Lorenzo. I think it was a very delightful audience experience to listen to you speak. When you hear people saying amen in their seats, and when you see people taking notes, I think, ma'am, are you running for office? Thank you for sharing with us the challenges and the nitty-gritty of what it would take for us to achieve the points set out by Dr. Tayag. So we all want to align with the SDNs. We're still in the pursuit of the decades-long effort towards primary health care. We're getting there with the dedication that our speakers are showing us. not just in the excellent slides, but also in the passion that they show in their careers. Now we want to show our thanks to you, so may we call on academicians Montoya and Dance again to show our token of appreciation. Thank you again, a big hand for Dr. Loren. So another guiding light in our efforts today, I think, is the next speaker. Dr. Lorenzo also already mentioned and pointed to Dr. Destura, Dr. Salvador Isidro Destura, we know him as Dr. Buddy Destura. As large as the challenges that we've just heard about are, it's reassuring to see that subsequent generations continue this fight and exemplify the same ideals. And Dr. Buddy Destura is here to speak about primary care in Philippine health professional education. And I think this is a reassuring note to start on before we go to the workshops. I know you have many questions after the first two speakers, but we'll have to reserve that for later. Let's go first to what are those kinds of responses that we have. And as Dr. Lorenzo said, these have been going on for 30 years. Dr. Destura finished his Master of Public Health at the University of the Philippines as a class valedictorian. He obtained his degree in medicine and Bachelor of Science in Community Health as a scholar in the same university, and his Bachelor of Science in Nursing at Immaculate Conception College. Dr. Destura ranked second in 1993's midwifery licensure exam and ranked 10th both in the 2004 physician licensure exam and the 2009 nursing licensure exam. Besides his academic achievements, his accomplishments include serving our countrymen as doctor to a barangay in Sorsogon. I think this was a remote area, classifiable as a GIDA. He was municipal health officer and municipal project coordinator in the rural health unit in Kasiguran. He was consultant at the World Bank for women's health and safe motherhood projects. And currently he serves as professor and dean of the School of Health Sciences, University of the Philippines, Manila. Let us all welcome Dr. Salvador Isidro Destura.
A pleasant good morning to everyone, to our distinguished guests, colleagues in the health profession, and other guests. Dr. Dance told me to discuss something about primary care in the Philippine health professionals education. And I told him I would like to focus on my school, the School of Health Sciences, because that is our niche. And before I continue to discuss, I would like to tell everyone that while we are championing primary care in our training, it doesn't necessarily mean that this is the only way to go. There are, of course, other best practices from other academic institutions, in which I think some would be able to contribute later on. So let us proceed. Next slide, please. So just a brief background about the School of Health Sciences. It was established in April 1976, initially as Institute of Health Sciences, or IHS. The board approved the establishment of the Institute of Health Sciences in Tacloban, Leyte, and it was envisioned to be a bold and innovative approach towards rural health education program by producing functional health workers at the various level of the curriculum. So it will complement rather than copy the present program at the UP College of Medicine, since it will cover the whole spectrum of the healthcare delivery system. The UPCM will maintain its present role of producing the teachers, specialists, and researchers, while in our case, we will focus in rural practice with the end in view of providing program model applicable to the Philippines and other developing countries. And of course, we have here actually the pioneers in the development of SHS. We have here Dr. and former UP Manila Chancellor, Dr. Domingo, and of course, Ma'am Lynn Lorenzo. Okay, next slide, please. So the vision of the School of Health Sciences is to be a relevant center of excellence for innovative health human resource development for the attainment of health for marginalized Filipinos in the context of nationalism and globalization of the 21st century. And if you look, next slide please. If you look at our, before the mission, we'd like to show you that the School of Sciences is located actually in the 3 major islands of the Philippines. We have one in Baler, there in Baler, Aurora. And in the Visayas, yung regional po namin campus, which was established in 1976. Okay, thank you. That's in Palo Leyte. And the third one actually is in Coronadal, South Cotabato. And I would like to acknowledge the presence of the Vice Governor of the Provincial Government of South Cotabato, Sir Vicente De Jesus. Right now, they really have the best support among the 3 campuses right now. And thank you so much, sir, for supporting the School of Sciences. Thank you. So as you can see, that's our stepladder curriculum, where you can see that our graduate would finish 3 courses from, it starts with the Certificate in Community Health Work, or the midwifery program, followed by the BS Nursing, and then the Doctor of Medicine program. And in between this program, we had the period we called service leave. So it's where our students return to their sponsoring communities where they apply what they have learned. And as you can see, we can produce a functional health workers at all levels. Kapag di niya matapos yung nursing, at least naging midwife po siya. At hindi naman po siya naging doktor, nurse midwife naman po siya. And that is my case. Actually, I'm a doctor, nurse midwife. Okay, so if you look at our mission, it says we have a lot of mission actually, but to highlight the 2, of course we aim to develop relevant and excellent health practitioners committed to serve the marginalized sectors of the country. And also develop innovative undergraduate, graduate, and short courses attuned to the health needs of the country. This is precisely now, I think, the call for us to help the project to be able to produce the primary care workers, at least help contribute at least. So when we talk about community-based health professionals education, it's basically the provision of healthcare training aimed to meet the needs of a future health professional. In the case of the School of Health Sciences, it's the midwife, the nurse, and the physician who will practice in the community setting. Services given or made accessible at the community level, which we call in the primary care context the first point of contact or the first contact care. And the training aims to equip the learner with comprehensive knowledge, skills, and attitude to assess, manage patients and families who present with a health condition, manageable at all levels or refer as appropriate. Okay. So, in the Philippines right now, there are several professionals that are actually doing the primary concept function. And just to name a few, we have the general practitioners, the private physicians, school physicians, the rural physicians, the MHOs, FAMMed, and at some point, some competencies, the general internal medicine, nurses, physical therapists, and the allied medical profession, of course, midwives, and even dietitians. So, recently in the School of Sciences, we had our curricular review, and I'm happy to know that the consultant of our curricular review is here, Professor Lynn Lorenzo. So we reviewed actually based on the goal to have an outcome-based education. So, to be able to come up with the curricular proposal in terms of the medical program, we look at first, of course, the CHED recommended program outcomes. So these are the following: demonstrate clinical competence, communicate effectively, lead and manage healthcare teams, engage in research activities, and so on and so forth. But for the School of Science, because we have a unique mission and vision, we just modified it a bit, in which in this case, like for example, in the first one of the program outcomes is to demonstrate clinical competence. We now focus particularly in primary care and integrative medicine. And also when we talk about communicating effectively, that's public health advocacy. And leading and managing healthcare teams is on the public health setting. Okay, and also when we talk about research, is health systems based and community-based research. And for collaboration with professional teams, it's a primary healthcare team and the primary care team. So, we also defined during our curricular review what are the roles and competencies of a Doctor of Medicine graduate of the School of Health Sciences. Napakalinaw po ng aming goal, ang magkaroon ng produce namin. We want to produce primary healthcare physician. And so what we mean by that, these are the roles of the primary care physician. in the clinical aspect, we want them to become the primary care provider and integrative medicine practitioner that is blending both Western and Oriental medicine. We also want to produce health leader and manager, health information manager and advocate, health resource manager, as well as health researcher and innovator. Okay. So, why primary care? Why we focus on that? It was actually mentioned a while ago that primary care is, for us, the best approach at this community or home setting because it is person and people-centered. It is based on needs and not based on over specialized care because it's more comprehensive. It's also cost-effective. The management of health conditions would need less resources at the primary level of prevention of care, particularly health promotion and illness prevention, versus when the patient now is at the other end of the spectrum, in which most often than not, they are into financial catastrophe. Particularly if you have a curative and rehab care system, which is highly commercialized and overly deregulated. Okay. And also access, because it talks about first contact care and the healthcare service opportunities for people living in the far-flung and gilly areas. Okay, they are served with that. And of course, the continuity of care, where coordination of care, including social services, among and at higher levels are achieved. Okay. So we have this proposal in terms of what are the possible learning outcomes of our graduates. So perhaps this can be a guide to some of our participants when do their workshop. In SHS, we aim that given an individual, family or groups with common health conditions in a community or home setting, our graduate will be able to competently provide, number one, first contact and continuing care using both conventional and complementary medicine, using appropriate technology and medicine. Also, they will be able to competently provide counseling and health education, including health promotion and disease prevention. Okay. And again, given the same setting, our graduate will be able to effectively coordinate clients concerned with other health professionals and partners in holistic care development. And when needed, refer triage cases needing secondary or tertiary care. And of course, to manage client information. And not to leave out, sorry, it's supposed to be, I think, the first one. Given the same setting, our graduates will, of course, be able to establish rapport and working relationship with our client who is well-informed, consulted, and an active participant in his or her care, including decision-making. Okay, so, and this is an overview, a snapshot of how we train our students in terms of community-based healthcare provision. So the Doctor of Medicine is about 20 quarters or 5 years. 1 quarter is equivalent to 11 weeks. So we have the series of subjects. Okay, we're using actually the organ system-based approach. Okay, and if you look at the exposure to community of the School of Sciences, we are very community-based. The focus, for example, for community clerkship, we have 2 quarters to 6 months, and the hospital clerkship is 1 quarter. And the difference also for the internship program of SHS, aside from a 1-year hospital internship in the school, there's also a 4 quarters or 1-year community internship where our students are rotated in the health center, birthing facility, TBLS facility, and also they conduct home visits or primary care. And in terms of clinical management, they are guided by clinical practice guidelines and things that they have learned actually in the nursing and the midwifery program. So this is again a snapshot of the curriculum design for the nursing program. Actually, this is based on the proposal. This is not yet final. We're still working on it. So we hope that the nursing program also, when they go to the community, they have intensive practicum for 8 weeks, and the rotations is very similar. But again, they are given trainings on how to manage cases using certain guides like the integrated management for child illnesses, the integrated management for pregnancy and childbirth, and also related to emergency or emergency care and mental health care. So this is also the midwifery program in which we're adding some quarter, and these are the sets of subjects which will help our graduates manage cases at the community level. So you can see the community exposure. We have 4 sets of community practicum, and there's also a practicum on health facility management, and the rotation is more on the community level and the public health setting. And again, those are the set of guides or clinical practice guidelines for our students to be able to handle patients. So, the School of Health Sciences actually has been existing for the past 40 years, actually. About 40 years, and been producing health workers and retaining them, actually. At least 90%, 9 out of 10 of our graduates stay here for 30 to 40 years, actually, as public health providers. Okay, thank you.
Thank you very much, Dr. Buddy Destura. If I may state the obvious, I think everyone sees that Sir embodies almost all the team members of a primary care team, and that's a very remarkable and inspiring thing. And I was thinking of submitting to PCHRD, sir, something about cloning para ma-replicate. Pero I think what we're doing here is sort of to emulate that example, that the interprofessional linkages and ideas and the replication that happens when you teach these ideas for 40 in a school that's been around 40 years is what we're trying to do here. We bring people from different sectors, different cadres to this event. So again, that's a thank you to NAST for helping organize this and to everyone who's participating. Picking off from what Doc Buddy has shown us, which relates to what the HRH lecture of Dr. Lorenzo was about. So I guess, sir, that speaks to some of our discussions before on scaling up something like this already. So we'd like to show our appreciation also to Dr. Destura. So if I may call on Academician Montoya and Academician Dance to present our certificate and token of appreciation to Dr. Buddy Destura.
Good morning. So to discuss the ongoing research and development in primary care, the PPCS experience, or the Philippine Primary Care Study experience, is Dr. Jose Rafael Marfori, or Rafi. Dr. Jose Rafael Marfori is the Assistant Program Leader of the Philippine Primary Care Studies, a research group formed at the University of the Philippines to innovate primary care to the national government. He brings to this multidisciplinary role of a diverse background spanning from the World Health Organization Regional Office for the Western Pacific, or WHO Pro, or WIPRO, where he contributed to the regional strategies on health, workforce policy and planning, and integrated service delivery at the Equity and Social Determinants Unit, and stock taking of WHO reforms in the Western Pacific region from 2009 to 2017 at the Country Support Unit. The Department of Health, where he served as medical officer at the technical office, or at the Office for Technical Services, overseeing national public health programs, and the UP Manila National Institutes of Health, or NIH, where he was a research associate for the Neglected Tropical Disease Study Group. Since graduating from the UP College of Medicine in 2011, Rafi has pursued health system strengthening from simultaneous roles as a junior surgical staff and ambulance and clinic physician. He soon took up a teaching position at the Ateneo de Manila University while performing research at the UP Manila NIH. Throughout this period, he co-founded and led Chiron Medical, Inc., a social enterprise aimed at sustainable, accessible primary care. Chiron won a grant from Grand Challenges Canada, concomitant with his scholarship, which he declined the Grand Challenges from Canada because of this scholarship. With the School of Population and Global Health in the University of Melbourne, where Rafi obtained his Masters of Public Health in 2015. Alongside PPCS, Rafi is currently assisting the Department of Health National Capital Regional Office to set up hospital referral networks while mentoring students at the Ateneo School of Medicine and Public Health. Let us now welcome Dr. Rafi.
So good morning. Short version, it's me again. So thank you for sparing me from introducing myself. So Dr. Rafi reporting, are part of Philippine Primary Care Studies, the co-organizer of this event. And I guess we're excited to share with you some of the results of our first year of piloting a primary care model, from which we encountered the need to train, to get more people on board with the kind of primary care model that we're piloting. And so we'd like to show the concepts behind that and how these align with because it places the primary care provider between the comprehensive concerns, or all of the patient's concerns on the one hand, and all of the health system's resources and components on the other hand. So that's a navigator role. And our logo actually tries to embody that. It's a primary care provider guiding a patient by the hand to navigate the health system. Otherwise, it's very overwhelming. So we really want patients to have a very delightful experience in the health system. I'm listening. What's often missed here is that relationship embodied by that logo. That is a continuing relationship, and continuing care is the fourth function. Continuing in two senses. One is, no matter which service the patient goes to, even when admitted and so on, the primary is there. That's your friend, that's your guide through the health system. So always informed, always easy for you to access and to talk to any concern. And continuing through life. No? In your next episode, years later, maybe you were asking about whether or not you should get the dengue vaccine this year, and then 10 years from now, you're asking about a different vaccine, or maybe that's too political a joke for this setting. But the point is continuing. So it goes back to the first contact, because for any subsequent first contact, your primary is your primary. So this is a system, primary care system. But as systemic as that is, I want to point out that this is within primary health care. We put I borrowed this slide from DOH also, just to put primary care within primary health care, the more comprehensive one. The truth is, it is pillar number 4, I believe, that services are a key part. And when I look at the history of primary health care, how it started in India with doctors who empowered and invented the BHW concept, it really starts with our professional excellence, our ability to cure disease and earn their trust, and then empower them with the knowledge we have from all the sciences and so on. So here's where we put primary care, right at the intersection. It's a very crucial layer, just like the position of the provider in the diagram earlier. So those 4 functions, very central, also within the bigger picture. It's central in the sense that you are able to, or it is central to public health and personal care, allowing you to transition from population-based and individual-based care. So what happens when it's missing? Very often something important, you know how important it is only when it's missing. And we don't just mean primary as in basic care, in the sense that if it's not there, oh, the poor are not going to have access to care. We actually want to point out that you can also have too much care. And this goes back to those 4 functions. So what's missing on the left is the obvious. First contact was gone, so there's no link, no guide to prescribe you the rest of your needs and coordinate those needs. That's too little care. But also you can have a lack of coordination. And for every disease that person had in the city, she had a separate doctor. So can you imagine her healthcare costs? Can you imagine her schedule just to visit these doctors? Not a very friendly or responsive health system. So that's how central it is. And when you have problems, or actually that's inequalities already. Some have too little, some have too much. You have that for access, you have that for outcomes. And so they're actually very strongly related. Just as an example, between the poorest and the richest in this country, you can have a difference of 13 times the unattended birth rate, or 3 times the under 5 mortality rate, or 40% higher heart attack rate. And these, if you look at them, are things that primary care could have done a lot about. I want to acknowledge also the slides, the source of my slides, academician dance. This is from the research group's slides really. Why do we think that primary care is key to solving these problems, or there's such big problems, HRH as mentioned earlier, here health inequity. And it comes down to what we believe are 3 of the major problems that cause these inequities in our health system. These 3 problems here, workforce shortage and maldistribution, administrative fragmentation and policy fragmentation, weaken our health system. And in changing times that were mentioned for the triple burden of disease, a weak health system is not able to provide the kind of equity that you need. Let's go to the first one, workforce shortage and maldistribution. So let's just use this diagram where we know that the experience of the rich and the poor are different with regard to the burden of disease. So worse off for various factors, but we often rely on the health system as parang the great equalizer. So if you access it as needed, if it's there for everyone because it's a good and strong and responsive system and accessible, like in the first diagram, then you have some sort of equalization happening. But the weakness occurs in this case with the first factor I mentioned, health workforce maldistribution, if it's not evenly distributed. So the more arrows for the poor are now transitioning to when the health workforce, or that blue bar that represents the health resources, migrate towards or concentrate towards those who can access them. And you add to that administrative fragmentation, which from left to right we have the rich and the poor. Let's now think also vertically of who is in charge of or responsible for these facilities, these health providers. So you have, it would look something like this. Your hospitals are the bigger boxes, your primary care units are the smaller boxes, and they're not connected. Some LGUs might not invest as much, some would invest, some private sector would migrate here. And you would have had lines here if ideas from many years ago, like the interlocal health zones, were active. So that someone who lives in an area with low prioritization of health could have accessed through the network the other services there. So the absence of those connections and the administrative fragmentation that we have is prolonging and worsening the poor access. And within each of those facilities, you have an internal struggle. You have a competition for the resources. Because part of our response has been, for every disease, we would have a program. That's the programmatic response. And this has plus and minus points. And the trouble is, with this kind of response, we lose the ability to prioritize. If we look at, for example, several of these programs, a single midwife might be able to address, or is trained to address. The red ones are for motherhood, the green ones are for children, and the blue ones are for neonates. And what happens is, those within each facility, there's may agawan, no, for the resources. How do we administer so many programs with just the same resources in each facility? And the hardest hit are those with little resources to begin with. So just creating all those gaps, we see that the poor will suffer more, and there's a limited ability to respond to the burden of disease. So what would it look like, the kind of health system that we were trying to pilot in our first study? So going back to that diagram, we wanted it to be something more like this. So those primary care units, it's like playing chess. We want to invest more in primary care. Put your resources there. If something is your priority, it better be in your budget and in your calendar. So in that sense, that's the investment that was made possible by PhilHealth to better organize this system. So it starts with putting money there to translate that into healthcare services and incentives, and everything follows. So PhilHealth made this possible. Now, these studies were PhilHealth saying, here's a research fund for primary care, and let's design a way to use this as a benefit. And we added on all the other components that would make that successful. And let me just describe some of that comprehensive primary care benefit that we modeled. First of all, we chose to pay per service rather than per disease package. And second, we opted to cover the rich and the poor, or in PhilHealth's case, any member, not just the poorest 20%. So we were expanding on the current PCD packages. What would that look like? So this is one of the unique features of the study. If you pay for disease packages, and going back to our diagram, every triangle is a disease package. Advantages and disadvantages, of course. No? The trouble is, if you don't have a package, if you don't have a champion for those benefits, and you consult for that disease, you might have to pay for yourself. The blue arrows are the ones that are covered. So we opted to pay for services. If the doctor prescribes you something, if the nurse advises you something, those services are paid for. And you don't have to think of which disease it was. So this expands it to make it more universal. It runs on the principle of risk sharing. So we allotted 600 pesos per head not per family. But not everyone gets sick during the year, so there's a sharing of the risk and a sharing of the funds. So when you do get sick, you can actually draw on more funds. And in our experience so far, about 98 to 99% of the patients in the facility actually fit within that budget. So to make this possible, those are the rules we established and sustained for 1 year. So when a patient during that year gets sick, they're entered into an electronic system, and then the record is made. So that's like registering them upon consult. Some of that data is for their profile, risk profile, so there was no need to actually register and profile out there house to house. Whenever they come back for follow-ups, that would be their continuing care, you just add on something more to the EMR. And there was some training involved for that kind of role, that kind of use of the EMR, and the diseases that would be seen during the year. So because of the EMR, we were able to see features like coordinated care, going back to the first diagram earlier, and regulation and monitoring, because you keep track of things. So when the patient comes back, the fund was already used before, that's kept track of until you use the 2,000. Monitoring, because we easily extract data from the system, like diagnoses or the drugs prescribed. So this is what it would look like. So at any point where the patient goes through this workflow, if something is prescribed at the pharmacy or something is prescribed for a laboratory test, if there's an entry point for a bit of data or a new billing that has to be made, that is kept track of and pooled for your monitoring. So some of the unique features of the study, as mentioned, so risk sharing, opportunistic registration and risk assessment, and the universality in terms of a more universal scope for services and a more universal coverage of people. So if I can just describe this in terms of what we call like the 6 R's, reaching out to patients, we have to recruit and retain, and that's partly the financial incentives and the training and career development. And that's where we go now today for the retraining. For something like this kind of system, something with the advantages that we've tried to incorporate, and the ability to regulate and reassess this system, what kind of goals do we have? So bringing this to today, in terms of training, what would it mean to train? Looking at the current situation, this may be sort of an exaggeration, but if we go with one model, which is per disease, you have a training program, and then from that one we would be assigning or pulling out health workers, then it would really multiply and make some things redundant. And this is something we can reframe. If we start to see, for example, just as an example, in all of these trainings, in all of these programs, what is it that the nurse really does as her role? What is it that the BHW really does as his or her role? And that pattern you can extrapolate and put together from that role. How do I become good at that role? What skills and knowledge do I need for that role? And so each of these boxes would become a sort of module, or at least an idea for today. We're just proposing this. It is a research. It's something we are asking your help in. We need your input for it. And so this is what we encountered as sort of a need. To deliver that kind of system, we need a primary care team and the sort of interprofessional, networked collaboration and skills so that they can work together in, like those diagrams we showed, the patient flow is smooth, there's an integration. If something is prescribed or used in some other part of the service, it's coordinated and you can keep track for the payments and the data. So for this slide, the main point is that for each of those parts of the system, we have a set of objectives, and those are the things that we have findings on. But I'll just focus on a few because we're just focusing on the retraining part. But I guess what better way to inspire the kind of training that we hope to achieve than the results that we've had. So, for example, in healthcare worker satisfaction, so we administer a questionnaire on different areas of work satisfaction, and we find that before and after this intervention, the one with the big rise was compensation. So only 50% were happy or scored 4 or 5. It's not too bad, but there was a big jump from 50% to about 2/3 being satisfied, very satisfied with their work and compensation. But the working conditions and the job contentment and morale were actually quite stable. In terms of healthcare worker knowledge, we administered a test, and this, I guess, shows you how comprehensive primary care can be. And the nice thing to note was that the areas where we had trainings, just like the trainings we will be thinking about in the workshop today, those are the areas where the scores really jumped. One even jumped to the top spot, reaching 73% of answers answered correctly. This system was able to also monitor quality of care, so we're really talking about innovations that give, in a way, new abilities to the health system. So we can extract from the data things like how many hypertensives do we have, and how many of them are on a certain drug, how many of them are really getting BP under control. But for a system like this, we would be thinking in a sort of different paradigm that I hope came out in the previous lectures also. So that's it. Last inspiring thing would be, when we implemented this system, initially, out of those who needed a consult or consulted anywhere, only 9% were using this facility. There were many facilities that this survey covered. But with this program, it rose to about half. About half of those consulting brought their consults to this provider. So I would like to go back to the 4 functions at the start. This kind of relationship forming, trust building, going first access to some consistent place that becomes your primary care provider. That's your first contact. And out-of-pocket expenses, remember this was a PhilHealth fund, so initially there was no coverage for those outpatient services, but towards the end we covered 14% of all primary care expenses. And while that seems low to some people, it actually also is significant in the sense that the survey covers all the facilities they were using, and around half were using other facilities. Only one facility had the program, and we were able to achieve 14% of the expenses being covered in a single year. And for hospitalization, which is a good outcome for all diseases, it doesn't discriminate among particular diseases, so it's a very comprehensive one. Initially, 15% of the families surveyed had some hospitalization in the past year, but this rose to 26% at first. 2 things there. This could be because there's a better pick-up rate. The primary care doctors are making referrals. But later on, we can also expect this to go down as primary care gives earlier, better outcome. And finally, we saw a steady rise in the utilization rate. There was no spike, there was no sudden abuse of the system when we announced that we had covered services with PhilHealth. And the big fear, I think, in covering comprehensively the primary care needs of a population was how much would it cost to cover everything. And what we found was it would only cost about 700 pesos per patient who was seen that year. That's about 3,000 patients. So thank you, and I hope you were able to see some of the concepts that we will be using for the kind of training that we need for a more systemic and comprehensive, innovative primary care system.
May we call on Academician Jaime C. Montoya and Academician Antonio Miguel Danz to present our certificate and token of appreciation for Dr. Marfort.
I'm not sure I should say thank you, Dr. Marfori. So, but thank you very much for your attention. We will now proceed with the open forum. and the proposed drafting of the training objectives. So I'm sure with everything that's been presented, we saw the big picture, we saw the challenges in achieving that big picture, and we saw some ongoing and long-standing, an entire school dedicated to that school of thought, and some current innovations also in bringing in the financing for that kind of human resource development. So we're opening the floor for questions. Yes, sir. We have a microphone.
Thank you very much for all of the speakers, very enlightening. Just like to ask, one very important component, I'm sure you know this, of primary care is health education and disease prevention. So I'd just like you to, maybe the other speakers, to what are, for example, the study you mentioned, how much of this component was actually considered, and you actually put a cost into it, because of course you need, to train people on how to talk about health prevention, disease prevention, and some of the tools that can be used for disease prevention, for example, aside from education, advising patients, also, food safety, water safety, vaccination, all of these issues. I'm sure this is actually a crucial component, because it was very interesting, the hospitalization percentage that you mentioned should actually go down. If you think about it, if your primary care is really running and people are regularly consulting, you're actually able to catch them at an early stage, or in fact may not even need to consult at all for a major hospitalization.
Thank you, sir, for the big question. I guess I'll break that up into several questions. So the first one, easiest to address, the last one. The hospitalization, sir, even when we present to Philadelphia, we say there are two possible outcomes really, especially at the early stage. An increase at first is normal and expected, because if we assume that primary care is weak at first, then we are missing out on correct admissions or people who need care. And the lack of access initially, some of the responses we expect are that people don't consult or wait until later or self-diagnose or self-treat, and these lead to bad outcomes that when you do start the primary care system and pick that up, there's an initial spike. Second is the preventive measures, and this goes to the early part of your question. We do expect a decrease in the mortality or morbidity, but that does take some time compared to diagnosing something that's already there, that has developed as a symptom. It does take time to prevent something. It does take time for an attitudinal shift for patients to start consulting earlier. When you kick a habit like smoking, for example, it takes a while for your lungs to return to their non-smoking rate of deterioration compared to the one with smoke. So the other question was, or the initial part of the question was it, sir, about where we place, or what do we learn about the cost of those preventive and promotive? I guess the first part of my answer is the monitoring of it. We are able to enforce and have a look. We cannot do anything unless we know if it's going on, how much it's going on. So if I can go back to, you have that slide? The quality of care monitoring, because we have an electronic medical record system, we are able to dig up data like, what's the word smoking in the history? At the very least, it's a good start for seeing if patients are asked about their history of smoking. This is still clinical, I have to say. This is still in the clinic, in the patient-doctor interaction. And if we extend this more to a community setting now, which we're going to be thinking about when you see the handouts that we'll be working on, it's not just patient-doctor. We do think that in the community setting, the barangay health workers will be face-to-face and talking about preventive things also. And then, so while Sir is going to the mic, we also do place this within the primary health care, the more holistic one. This one is the services part.
Yeah, the advantage of the starting the primary care, testing of a primary care model in UP is that there are 14 well-trained family physicians in the So we didn't have to worry about competence at that time. In terms of giving preventive measures, our concept was that the health screening, risk assessment would happen on the first consult. So we call it opportunistic screening or opportunistic evaluation. It will help reduce costs. As I think one of the surprising findings for us was how low the cost per person was for the whole year for all the medications and tests was only 600 to 700 pesos. So that was our goal, was to test whether opportunistic screening would work. So we don't do the risk assessment with them coming, in a healthy state. I want to be my blood pressure taken. Tell me, am I at risk for that? We do it when they get sick. That way, you beat two birds with one stone. You're able to treat the cough and cold, and at that same time, you do the risk assessment and take the blood pressure, ask them if they smoke, take their weight and height, etc. So it's two birds with one stone, which is maybe one of the reasons why there were a lot of savings.
Yes, sir. Another hand.
I'm Dr. Inday Lance. I'm part of the primary care. The better half. Oh, si Jimmy yung nagsabi nun. So, the primary care studies. Kasi baka yung iba hindi familiar dun sa study, project. It's actually 4 sites. So what Rafi has presented is the one that was done, yung corporate setting, that's the UP system setting. But we'll be starting with the rural as well as the GIDA setting. So very important, Tony highlighted the fact that the first pilot study in new results was in the UP infirmary or health UP infirmary. So marami ng family care physicians. So this workshop is very important kasi yung retraining component wherein we will have to strengthen our primary care delivery, and healthcare workers should be prepared for that, especially in the rural area and in the GIDA. So yun yung training component na pag-uusapan natin today. So just to give it in the proper perspective.
Before the next question, may I invite our speakers to the front also so that we can address the questions and the audience can address the questions to us. Yes, sir. Can we introduce ourselves also when we ask questions?
Dr. Olveda, I'm with NASH. I have seen the very important contribution of primary health care because I have worked in very remote areas in North Samar and Leyte, and I have seen people with very advanced disease in the field, severe hypertension, severe tumors, and they cannot be treated anymore. So I think if they were prevented very early and they were picked up, and those cases were prevented to grow bigger, that could have saved very much in the care of people for health. And even if we build up the hospitals, primary care hospitals, if the primary health care is not established, this hospital will be only overwhelmed. So the other is, I think because of training and retention of trained people should be also put in the budgeting or looking for funds, not only because of caring patients. Because the program of your curriculum in Tacloban, for example, train people to become midwife. If they are okay, they become nurse, then they become doctor. And I have seen people who were trained from those schools working with us in the field. They are very good. But when the nurses were in demand in the past, the other medical school established your training in the step ladder program. When the nurse became very the demand for nurses increased very much in other countries. Other medical schools established a down-step training program. The doctors became nurse, and then they became midwife, and then they became workers in one house looking for the care of one person. But in the process, they were trained also from doctor, midwife. But the only problem is those who became doctor, they wanted to become nurse because it's easy to become nurse if you're a doctor. And then they say that if they want to become a nurse, it's easy to become a midwife when you're a nurse. But eventually their intention was to become a maid, like a maid in Manhattan. So the issue there is really retention. How can you retain people? How can you retain people even they are trained? How much it will cost, and how to not sustain it? Thank you.
So, any of the speakers may respond as a recap. So we do have observations, sir, of patients coming in too late. Sounds like a self-reinforcing cycle of they don't have access, so they don't claim the access. And then you suggested a budget for retaining also, and citing an extreme form of the retention problem where there's downstepping, and I think I heard one of the speakers say underemployment as a result. And so the question is, how do we retain them?
Thank you for that question about retention. As I mentioned, in the School of Health Sciences, at least 90% of our workers stay and serve in the far-flung areas in the Philippines. And one of the reasons for that is basically the way the curriculum was designed. It is community-based. The training is more focused on community setting. That is where they are more comfortable. Doon sila nasanay. Their competence, also the rotation and everything. And perhaps also the length of stay in the community. I think compared to other schools, mas mahaba yung exposure ng aming mga graduates doon. And so, it's like parang kung saan ka nasanay, doon ka mag-gravitate. So yun ang basically yung nangyayari sa amin. Other than that, of course, we also have the return service agreement in which that is also being implemented in the University of the Philippines and Manila. SHS actually even before that was formalized in UP Manila 2011, that has been the concept of the School of Health Sciences ever since it was established. So for every year of study, you're going to do a return service of 2 years. So like myself, because I finished 16 years of SHS education, my minimum number of years of service is 16 years.
Okay. Well, thank you for those points that you made, which are very valuable. In terms of the cost of the 600 to 700 cost, I agree that once you think about a system, you will have to really look at other costs such as training. So that's something, but maybe the basic in-service, the basic pre-service training cost will not be included anymore. But any in-service training or development that will go on should be inputted. Otherwise, this will not be done, and because the program will be underfunded. The other thing is, I think the team will have to think about linking the primary care system really with the bigger system. No? I am acutely aware of the fact, and I really appreciate it that you're looking at the smaller direct primary care system. But from our work at the UHC study group, one of the things that we have learned over the years is that you cannot divorce the primary care transactions from a bigger system, which is primary health care. Case in point is, should all the care be provided by somebody else external to the community? Or should we, in fact, be training the people themselves to provide their own care and even to keep healthy so that we do not need to be providing external care? Questions like that need to be asked, because then the training that we will design or the training approach that we will use will have to take those into consideration. So is it just really provider-focused training, or should it be training of providers put together with family members who will then provide some of the care or at least take care of themselves?
So I'm aware that there's a patient focus which they can seriously includes empowering the patients also. Is there just a bit of follow-up on that question, sir? There was a mention of the return of service program, for example. I just wanted to ask if the panelists might have something to say about Thailand, for example, is doing an even more extreme version of the return of service agreement. I think it's mandatory for all graduates or something like that. And yet, it still seems like a temporary measure. And I was just looking at the SHS model and how that's been replicated by Zamboanga, for example, with the key feature for me being the lower entry requirement, person style, what that might say about the kind of candidates, root causes that we have.
Before you, sir, actually another important strategy that I failed to mention, but I think was already being mentioned by Ma'am Lynn, is that our recruitment comes from the place. The scholar is endorsed by the community. So essentially, the scholar will return to his or her community to practice his or her health profession. It's not temporary. You have to be there. Actually, there is a saying in it. We always tell that in SHS, meron forever. Basically, the social contract is actually a forever contract. Kasi, like for example, if in my case, I'm from Sorsogon. Eventually, after after my academic career, perhaps there's this longing to go back again to my community to serve. That's the usual tendency for graduates. And the return service, though not implemented in other colleges or state universities, perhaps that can be recommended, but that requires a long discussion. But that is recommendable.
Maybe something a little beyond training or in-practice training, maybe for curricular or other. And this forum also in context we hope to have a bigger picture. Later on it would lead to, as Dr. Lin was lecturing, the linkage between the in-practice training, which we're going to discuss now, and the curricular long-term. Yes, sir.
Good morning. I'm Dr. Jeremy De Guzman. I'm from the Ateneo School of Medicine Public Health. Two, I guess, first is I'd like to comment. Congratulations for SHS on its history and its success. I would have loved to read your successes on the journal, so perhaps there's space to actually have a discussion among the different medical educators, because we're also interested in having this kind of social accountability across medical schools. And I was in discussion in my table. A good statistic is actually more than half, maybe 70% of all medical schools are actually private. So they need to be in the discussion because they are producing a lot of our graduates. And if you notice nowadays, go to Facebook, more than 50%, or maybe more, at least in the UK as I've read, of primary care physicians or GPs are not in training or not in any career development or formal systems. They're all moonlighters. If you don't know where they are at the moment, that is a looming problem. We need to get them, to organize them, to do more aligned work with our objectives. So that may be something worth looking at. And these are my more specific questions for Dr. Marfori's team. First is the 700 pesos annual cost, is that only direct cost or does it include indirect costs? So that's my first question. And the second is there a indicator in your study about continuity of care where higher institutions actively refer patients back to your primary care facilities? Thank you.
Is there a response for the first question on social accountability of private schools?
Actually, that is already in discussion even at CHED. So there's a technical panel on health sciences education, and we've been talking about that. In fact, with the shift to, I don't know if everybody's aware of the fact that we have already shifted to outcomes-based education. We're trying to identify ways right now that we could actually influence even lifelong learning as part of the outcomes that we would like to see from education. So policy-wise, what CHED is trying to do right now is to get each of the professional cadres think about how to support the professional graduates after school. Right now, our system is that after you graduate from any health science professional school, they will only track you where you are, but they have no responsibility over your post-professional education life. But that is something that we would like to change, and so we hope that the moonlighters will not only moonlight for income, but will also moonlight for exposure and training. Now, for the moonlighting, I think we need to talk about, in the future, maybe not here, the health labor market is really pushing moonlighting. If you look at it, there are no real positions even for young doctors. You have in hospitals, except if you do residency training, or even, especially in the rural areas that do not have residency programs. So the moonlighters go to where there are positions that will pay them on a part-time basis that they would like to go to just to augment their income or while waiting for positions for residency training and all that for doctors. For nurses, it is really going to the NCP program, the deployment program of DOH, which pays much higher than the usual nursing positions. So I think we need to, if you were to look at that as a system again, from linking pre-service training to in-service training, that is what the academic institution should be doing. We train our graduates based on our perception of what they should know, but we have to consider the fit for practice and fit for work readiness that they should have once they graduate. I think that's something that we are not looking at. So if it's fit for work, where is the work required? It's not in the hospitals in the metro cities, it's in the rural areas. So why are we training them in specializations that may not be accessible in the rural areas? So that's something that the academe needs to think about. And UP, I think, is also thinking of engaging the rest of the health science community to come up with health science SHS-like programs. Initially, our dream, and Dr. Domingo can speak to this, our dream when we were pioneers at SHS was we wanted a school of health sciences in every region. And that would have solved our problems if we did it. But there were few takers. We need inputs. So like the government of South Cotabato that committed land, resources to put the school up was important for the university to bring in faculty, training, and all of that. So it's a partnership. And we will, I think UP will be ready in a few months, if not a few years, to do this.
So we're talking about a continuity or an involvement of the institution moving forward from education, graduation to early work, and moving backwards from that kind of involvement. How fit is the curriculum for that kind of needs out there? And then for and matching some of those graduates to the existing needs also, like the nursing program. So in answer to your question, 698 pesos in our study was per capita for the whole year for a unique patient who was seen. So if you were seen, that's how much was expended. That's expenses. But there was some subsidy, just like the salaries of doctors, that's paid by UP. Or in the case of an LGU, it's paid by the LGU. So the PhilHealth money did not pay the whole cost, the true cost. The true cost was 730 per unique patient per year.
Indirect though, indirect.
It does include indirect. We did a costing study. In the interest of time, I had to breeze through it, but we did a costing study of all the resources, direct and indirect, that went into particular services. So just a reminder, if we could parse our questions to make them brief, so that we can accommodate more. I think there was a question from Dr. Domingo.
I'll wait.
Okay, sir. Thank you, sir.
Yeah. Good morning. Cecily Santos from the Philippine League of Government and Private Midwives. This is in connection with the presentation of Dr. Lorenzo regarding the health workforce needs and challenges, which is actually the problem of health workers, a perennial problem, particularly the midwives, being the frontliners of almost all the basic health services being implemented by the Department of Health, even before and after the devolution. So much has been said about the challenges, and we do hope that during the workshop we could do something about that. The workforce, particularly the midwives, is a perennial problem with regards to the distribution of health deployment, with regards to ratio per population, the training, etc. Just a bit background there lang, ano. The midwives as of today has more or less 170,000 registered with the Professional Regulation Commission, 18 to 20,000 works at the public health, some of which are retained in the private hospital, in the government hospital, and some of which have their own birthing center. So medyo maganda na yung scenario. Meron na silang ibang resources, no, other than being a public health. So, perennial problem in the sense na much has been said, much has been read. Laging ganun na lang yung nakikita nating scenario, but medyo wala pa rin tayong nagiging action. Ano? The National Deployment Program for Nurses, napakadami ng mga na-deployed na mga nurses, but comparatively speaking, yung midwives, hindi masyado marami yung deployment. And comparatively speaking din, yung salary, which somehow nagkakaroon din ng problem pag na-deployed yung mga nurses from DOH to the local government unit because of the salaries. Kasi mas mataas yung ating NDP compared sa ating mga nasa plantilla na midwife. So sana makita din natin yun during our discussion. Ano? Kasi kami yung mga affected how can we be effective, no? Kung ganito yung ating environment. There is no enabling environment for all health workers. So sana we can do something about that. And about the presentation of the Dr. Destura about the course for midwives, we are interested to see that. Thank you.
Thank you, ma'am, for the comment. We do have limited time, so perhaps we can limit it to the two questions and short answers also. We can just converse them. And then Dr. Domingo.
So, ako po si Dr. Lani Nicodemus. Ako po ay family physician and I represent DOH FMRT Family Medicine Residency Training Program at saka po sa UP College of Medicine. Natutuwa po ako kasi marami nang may kasama na sumusulong para sa competent primary care practitioners. So, ang tanong ko lang, siguro dun sa study sa UP Diliman, you have emphasized or you have mentioned retraining and also probably not only for physicians but other health professionals. Yung if you have done IPE para maging successful yung inyong programa, yung interprofessional education. Because we're trying that in our department sa aming communities, yung IPE. medyo mahirap po if that was done in the project. Kasi very essential po yan, yung ganon para maging successful yung SDN, yung transit ng mga pasyente across health systems. Tsaka meron akong konting comment lang. We're doing actually, ma'am, practice-based training for municipal health officers. So trainers are going to the practices, baliktad na po. Dati po nasa hospital yung training, yung dinadala na po sa community, and we've been doing it for 2 years. Siguro hindi lang kami masyadong maingay po tungkol doon. But we simulate the SDN na ang training po ay municipal health officers, and then my district hospital physicians should go to that type of training, and then provincial health hospitals na gano'n. So they have better communication now. Dati may turfing, nag-aaway. So now they're somehow may good relationship with that different level. And maraming salamat sa DOH, FMRTP for that opportunity. Pero balik po ako dun sa IP.
Thank you, ma'am. So the short answer is, to some extent, we did recognize that need. It's a way of working. It's not just who's next door, who do you refer to for this, ganyan. There are mechanisms, there are competencies to become team players. That one, I would say it's partly why as we move to the expansion sites, we really put a focus on that kind of training, which is why we put up this forum. We do look to examples like several courses. I think of UP Manila, pharmacists, community medicine, and so on, nurses in the community being taught together. But that's curricular. We did go into areas that are existing and giving services, so it had to be in practice training. As much as we could do them together. But yes, we're looking for the input from this body, because we're again going into areas that are existing and working together already. But how to introduce the kind of real IPE that you're talking about, ma'am, we really want to disseminate those ideas also. So we have two more questions.
I'm Natalia Panto. I'm also from the DOH Family Medicine Residency Training Program. I'm a retiree from the UP College of Medicine in Manila, and my last appointment was in the community-based health program in Cavite. That's where I spent the last 3 years. My comment, first of all, is when it comes to continuing professional development that all health professionals should engage in, it is already covered by the by the CPD units required for you to renew your license. So I think there is already a motivation, otherwise you will not be able to renew your license. But the problem is, how are we going to offer these CPD programs? When I was in Zamboanga, I helped the Zamboanga Medical Center in their strategic planning workshop. I was able to convince them to have themselves accredited as a CPD providers for all the professionals in the hospital, and that will cover a lot, so that they will cover Region 9 when it comes to CPD units to be earned. Now, when it comes to the SHS, if you're interested, there is a book on SHS, and there are still copies in UP Manila, that's bringing healthcare to the communities. No? And the reason why UP Manila developed the SHS in Baler and in Coronadal is to ensure that the model will be available in Luzon and Mindanao. And it's working. Because the other attempts did not work, so probably UP itself will duplicate, so it's now working. Now, when it comes to SDN, I would like to reiterate what
is a good policy motivator for all professionals to undertake CPEs. The law says now that you have to have, or that policy says 60 units for 3 years, I think, before you can renew your license. However, if you see how the CPDs are being offered right now, they are offered in silos. So CPDs for doctors only, and for and I hate to say this, but when we analyzed how the CPDs were being offered, at least in nursing, there was no rhyme or reason. It was the specialty groups that wanted to come up with certain topics, whether they were needed or not, was not an input into the determination of that. Second, there's not interprofessional, they have no interprofessional characteristics. And so the local governments have been complaining about having health workers taken out of their posts just to be trained. And then in the end, there's no monitoring that happens. So after their training, were they able to apply their training, and did health outcomes improve? Those are the things that we who are going to be providers still need to do. Otherwise, in this project that we're working on now, HRH 2013, even USAID was saying 89% of the funds that they have given to the Philippines for TB, family planning, MCH was spent on training. But if you look at it, the outcomes did not change much. So we have nothing to show for training unless we really redesign it. And so I'm very glad that the primary care study is looking into this, because it is a problematic area.
I think in general, for regulatory moves to be focused on outcome-based regulation tends to be a big problem nowadays. So that's why, going back to our framework, we did put a reassessment phase there. We always have to see, whatever the intervention, how are we doing in relation to that point. Dr. Domingo, I believe, had a question also.
That question.
It's not a question, but a very short comment. And I'm sure Rafi, you and your group, being a high-powered group, Tony and Dahil knows more of this than myself. But I have to mention it. No? The data you present are good, but certainly cannot be used for generalizing. I know you know that. Even because, for one simple reason, the study area you have is very unique. Where in the Philippines can you find a health provider station with 15 well-trained, brilliant general practitioners? So, just to emphasize why this will already skew whatever result you have, is that I will make my own self as an example. I'm a super specialist in gastroenterology. If you bring a patient to me with diarrhea, you have to point a gun on my head for me to request stool examination. Totally useless in a case of diarrhea. History alone will tell you what it is, because that's what I studied. But if you transpose that in a situation where you don't have specialists like me, the likelihood is that anybody who comes with a diarrhea will get a stool exam, which will cost a few pesos. Or anybody with a cough will probably get a chest x-ray. Anybody with a hypogastric pain will get a urinalysis. This will jack up the cost significantly. And therefore, it is in this light that I look at your presentation. And I am happy that you are now going to do this on a different setting. Because our contention in the Universal Healthcare Study Group is there is no one system in this country that will fit all. Each system will have to be fitted in the particular circumstance of a given community. So I hope that comes in the discussion later.
Thank you, Dr. Domingo. Perhaps a brief response before we introduce what we're going to be doing. Sir, we agree with you so much that we wish we could invite you to say the same thing when we ask for funds as we expand to the other side. Because the truth is exactly as you said, sir. I won't elaborate further except that I guess the wording that we bank on from the DOH administrative orders and so on did provide us the leeway to try and do what you said. For example, as Dr. Tayag mentioned earlier, the wording is, it makes arrangements, so it's very empowering. We do, as difficult as it is, we try to do that in the communities where we live.
Right. Thank you for saying that. It will take some time for the people here, in the audience, to understand the concept of service delivery network. But we have to work very hard for it, because the service delivery network is not a referral network. It's not even restricted to interlocal health zones. Think of it this way. All those who will be trained in the training institutions such as yours, the health sciences, should never be trained if in the future they will not be a part of the network. So when they graduate, they should be matched to a network. Whether they will get paid, they will work on a voluntary basis, or they will have contractual agreements. That's the nice thing about the network. Everyone is matched. A patient is matched to a network, a health worker is matched to a network, a facility is matched to a network. When you look at return of service contracts, a law that will change the health workforce population ratio, improving the plantilla, these are stopgap measures. The paradigm for the service delivery network is that we work with what we have. Because those who will graduate, we don't have them yet. We work with what we have. What do we have? So we have the gainly employed, we have the underemployed, those who are changing their minds about their profession or their careers. But once they graduate from these training institutions, and it's related to health, they should be matched to a service delivery network. So, if you're matched to a service delivery network, then it's easy for the network for you to be navigated in all the facilities connected with the network. That will solve the distribution. That will probably address areas where there are no doctors, because it's not anymore the presence or absence that determines the presence or absence of this health workforce, but the arrangements made by the network. So imagine a barangay health station has no midwife, and because it's part of the network, then suddenly the midwives association, because they're part of the network, then midwives can be deployed there. And if arrangements have been made by the network, okay, for this period you're working with us, you'll get this. So everything is possible in the network, but we need your minds. Please work with us. This is a work in progress. Yes, this is a dream, but everything starts with a dream. So I hope you can join us in this endeavor of the service delivery network, because that network has all the possibilities that will address concerns in the health workforce, in financing, everything about services that will be delivered to our people.
So a shared vision and commitment to the same thing, so that everyone, supply side and demand side, can commit to this network and make it
and
real.
Ralph, while we commend your study, and I would like to re-echo what has been said, one of the unintended consequences of that is it can add to the fragmentation of the health system if your team of high-functional health workers are not connected to the network. It will isolate them, and that's fragmentation.
Yes, noted, sir. what we try to do also is to provide the mechanisms for them to work together. So, so with that, I know that I'm standing in the way of everyone and their lunch. So we do have one more thing before that. We have a few minutes. We would like to thank you everyone for your questions. And this time we're about to go to our breakout sessions, and perhaps we can introduce this first. So there will be facilitators for each breakout sessions. There will be 4. And to introduce Dr. Dan, I'll call on Academician Dr. Dance to introduce what it is we will be working on. The form itself and the format and the content that we'll all be working on in the breakout. And we'd like to thank our panelists also. A round of applause for our panelists for the panel.
Good morning, everyone. I'm Tony Dance from the UP College of Medicine. I'd like to thank Eric and Lynn and Buddy for the great lectures this morning. Eric highlighted the difficulties but the importance of service delivery networks. Lynn told us to advise us to grow humans, grow people if we want to push for primary care, and Buddy has emphasized the importance of a community-based training if we're going to move forward at all. Can you fix it? Yeah. So, just to orient you to the tasks this morning, or this today for us, the Philippine Primary Care Studies was initially developed, or the initial concept was for the DOH and the PhilHealth to be able to fund primary care. One of the big needs was, what are the costs? So our initial thought was, just do costing of different services. But then it became evident early on that you could not cost independently. You would have to look at costs within a healthcare delivery system. And so it evolved into an entire primary care system, and the pilot study is in UP Diliman, and I'll talk about why that was important to start with. So, just to re-emphasize, for this morning, we need to realign some training objectives for our health workers to address 4 important functions. Primary care is first contact. That's the primary care provider. Provides comprehensive care for almost all diseases, coordinates the service network, so there really must be a service network, and then is the principal point of continuing care. Last is a big problem in big cities where once you refer to a nephrologist or cardiologist, for example, the patient becomes a patient of that cardiologist forever, and now the patient has 2 doctors. And after referral to a pulmonologist, they go back every time. So, and these 3 people never talk to each other. So there must be a point of continuing care, a captain of the ship, and we think that's the primary care provider. But Eric is right, the primary care provider cannot work on his own. He needs to work within a system because there are other services that need to be rendered. So he's part of a system, a service delivery network. To start this morning, we'd like to develop a training system, a quick training system. I'll talk about that quickly, for the 4 important components of primary care at the moment. The primary care providers, namely the doctors, the nurses, the midwives, and the barangay health workers, without exclusion of other paramedical professionals who can serve within the service delivery network. These are the usual first contact of patients in a primary care system. Now, these were the strategies, and this was the advantage of the UP system. So we said to establish a primary care system, we needed to recruit. So we developed motivational workshops and estimated fees for service. We also developed an instrument for healthcare worker satisfaction. Are they happy? Will there be new hires? But we couldn't test that within 1 year. We needed to address the problem of training, so we had short lectures and workshops, and we had instruments to measure healthcare worker knowledge and the system is working or not. Utilization, out-of-pocket payments, hospitalization, and costing. And finally, we have a strategy for reaching out to the community. This was a late addendum to the overall strategies for the study, because we needed to communicate with the community and invite them and tell them about what was happening. So we have now brochures, ads, videos. We have a video featuring Lenny Robredo and developing some more. So we have people with different political affiliations. We had meetings with the employees, contractuals, the faculty, and we had an instrument to develop patient satisfaction. So the big task now is to transport this to a GIDA, a geographically isolated and disadvantaged area, and to a rural area, and maybe to a private practice. We haven't finalized the funds for that yet, but so far we have taken off in a GIDA area, which is Bulusan, and in a rural area in Samar, Bataan. So we have the strategies and the objectives which we can use, but there are a lot of problems. Siyempre, yung pinakamahirap binigay namin kay Rocky, siya yung assigned sa Bulusan. So he needs to think about establish a service delivery network in an area where there's one doctor seeing 30,000, 22,000 patients. There is no universally accessible pharmacy or universally accessible laboratory. Transportation becomes part of the healthcare expense to improve access. So we gave him all those problems, and he's been working in Bulusan for almost a year. And we hope to launch by April or May this year. So for today, we're focusing on retraining. A lot has been said about professional training, like in medicine, in nursing, and in midwifery. But right now, the immediate task will be with the workforce we have, who's already there, what can we do? Because it will take time for the family medicine training program to actually generate the numbers needed. It will take time as we get more people to train as nurses and midwives, and hope they will be retained. So we need to work with what we have. But the objective today is, if we could help the people who are out there already. In Samal, we have 100 barangay health workers, more than 100 barangay health workers. How can we help them to deliver the expectations in a primary care system? So, here's the table of proposed competencies and a proposed training objectives. We classified them, this is for the barangay health worker, into first contact. What's the role of barangay health worker as first contact? How comprehensive care, how much of comprehensive care can they deliver? What are their roles as barangay health workers in coordinating care? And the last one, which is continuing care, what's their role? And we have proposed training objectives. We hope you will go through them and criticize them. We will be dividing into 4 groups. One group for each of these 4 functions. And then given the proposed training objectives, we hope we'll come up with strategies on how they can be rendered in a training workshop for these people. So for example, if we look at the proposed competencies this is for barangay health workers, our proposed competencies for them. First contact, baka ganito lang, and I'm sure you'll have suggestions. Maybe they should distinguish between sick and health. Recognize emergencies and deliver first aid. Maybe basic resuscitation skills. Learn who to conduct to an emergency room. Develop communication skills and nurture patient trust, because that's one of the key elements of first contact. I like Lynn's term, yung delightful care. Unless it's there, we will not be the first contact, right? We will be the last resort. Now, what are the possible, I'm just giving you some of the concepts here. What are the proposed training objectives that will help them attain this? We should train them to identify common signs and symptoms, including those for emergency cases. Exercise relevant communication techniques for patients for first contact care in the community setting. Kasama yun, di ba? How do you develop a delightful program if you don't provide some training there and point out what the issues are? Demonstrate proper procedures for first aid and basic life support, because they're the ones there. And to safely perform the necessary steps in conducting patients to an ER, to use the most appropriate verbal and non-verbal techniques when speaking and listening to patients. For comprehensive care, what can they do? Maybe they should be able to perform basic history and physical exam. Doesn't have to be the extent of a PE that a doctor, nurse, or midwife can do, but certainly vital signs and knowing if a cough is urgent, needs urgent care or not. Perform and teach household remedies. Counsel patients on general disease prevention and promotion. So this would be the training objective. Distinguish among various common signs and symptoms, obeying routine measurements, describe these common signs and symptoms, be able to record and report findings, match various home remedies to their correct indications, and others. For coordinated care, the proposed competencies, they must be able to inform patients of available meds, tests, services in the rural health unit and the service delivery network. So they must know that for the locality where they practice. Communicate freely and effectively with the rest of the team. Assist patients with logistics for commonly occurring health needs, and recognize when does he need or she need to refer to a doctor, nurse, or midwife. And these are the learning objectives for that. And then the last is on continuing care. May role bang barangay health worker sa continuing care? It's very important. Because even if you undergo a bypass, you need to go home, right? You need to go home to your community. You cannot resettle in East Avenue to live near Heart Center. You need to go back to Tawi-Tawi or Ilocos. And you will go back to areas where your only healthcare provider will be a barangay health worker. So they must have knowledge and skills to monitor, rehabilitate, counsel, and provide continuing care under supervision of a doctor, nurse, or midwife. So again, this is going to be a chameleon role. How much rehab, how much monitoring, and how much counseling they'll do will depend on the other resources present in their service delivery network. And finally, the proposed training objectives. Interpret orders from other teams, use different options for reaching patients,
community-based skills for carrying out orders, relevant, accurate observations. Now we have the same thing for the midwives. So maybe I'll just go through the proposed competencies. So midwife, distinguish sick and well, treat and render preventive care, especially maternal and child health. And that's the main difference. Recognize emergencies, deliver first aid, and develop communication skills as well. Those are the first contact skills. The comprehensive care skills, basic history and PE, household remedies, counsel patients on general disease prevention, again on maternal and child health. They are the specialists. For coordinated care, the proposed competencies: inform patients of available meds, tests, and services, communicate, assist patients with logistics for commonly occurring health needs. So parang ang nagiging role ng healthcare provider, hindi lang tagasabi na kailangan nyo ho ng rehabilitation. Ang role niya is, ang rehabilitation service natin, meron ho ditong marunong. Or napakalayo, pero kaya ko pong gawin. Or napakadali ho, hindi nyo kailangan ako, pwede ko kayong turuan how to render the rehabilitation. And finally, for continuing care, so they need to be able to monitor, rehab, counsel, or render continuing care under supervision, render maternal and child health, and cultivate the trust and ongoing therapeutic relationship. Ano namang kaibahan ng nurse? First contact, they can distinguish between sick and well and conduct health screening. And they can treat and render preventive care for certain conditions, depending again on the characteristics of their network. For comprehensive care, we can do a basic history and PE, perform and teach household remedies, counsel patients on disease prevention and health promotion. For coordination, again, similar, they need to know the network, what their role is, when do they need to refer to a doctor. And for coordinated care, they should have knowledge and skills for specific parts of care for chronic conditions. Post-discharge and post-op, yung continuity of care. One of the pitfalls in hospital care is pag-uwi ng pasyente, there's no one to continue care. And that creates a lot of problems in health. Administration of parenteral medications in the clinic or at home, and be able to use the midwives and barangay health workers as extensions for their reach. Because continuing care, they should lead overall care on first contact, diagnose and initiate treatment, recognize and manage. Para sa amin, ang big role ng nurse is to manage. Even in the hospital, that's the big role. Ang doctor, susulat lang niya, take penicillin. The nurse needs to administer it, know where it should be taken, advise the patient on the side effects. No? So the real service or the real care is rendered by the nurses. And yeah, so sa coordinated care, again, know about the service delivery network. And sa continuing care, they should be able to follow up after someone is seen by a specialist and undergo communication and planning, etc. So that's just to give you an idea of the general structure. No? There will be one for doctors, a table for nurses, midwives, and barangay health workers. And keep in mind two things. This is not a degree course. It's something we can help the current workforce with. Maybe it can, in the future, help guide directions in professional training. But right now, that's not what we need. The second is, there will be several problems with wording. My suggestion is, let's not be engrossed with wording. If someone can write the general concepts and ideas, we will ask someone else to do the wording for us. So we need guidance. Corally with and yeah. So those two things, no? The wording is important, but not right now. And this is for the current workforce. It's not supposed to answer all our needs. If we want to launch by the middle of this year, how do we help the people who are there? Because there is a cry for help. They do need help. And we need to try and help them get organized and identify themselves as a team rather than as individuals. So Rafi, pwede ba ako yeah. Are there questions? There are questions, yes. We probably need to have a working lunch, maybe have 2 tables for each group.
Yeah, Doc Tony, what you have been presented actually, existing na yun eh.
Yes.
Yeah, yun na yung mga existing na ginagawa. From barangay health workers to nurses and midwives. Actually, it doesn't include pa nga yung expanded function eh.
Yes.
It is being performed.
We focused on primary care lang.
Yeah, primary care. But as I said, existing na yan. Lahat yung mga na-mention na yan, ginagawa na nila. The problem is, yung implementation natin.
Yes.
Because we have problem with regards to catchment area na. So much as we would like to have 1 midwives for every barangay, hindi yun nangyayari. So yun yung ating problem. Kahit na naka-define yan sa Magna Carta for Public Health Workers, hindi nagagawa yun. So you mentioned earlier na hindi siya magiging course to, not a course actually, but it's training. Pwede natin it was mentioned earlier with regards to the continuing professional development. Pwede po natin apply yan to be part para mabigyan siya ng corresponding credit units which will benefit all health workers.
Thank you for the suggestion. In fact, alam niyo po, merong mga, in some of the sites, doctors na specialists na gusto nila mag-primary care. So, sa UP nga, may ophthalmologist, gusto daw niya mag-primary care. So, he's requesting for some training in it. Many of us specialized and then changed our minds, di ba? Pag uwi mo, meron akong mga kakilala nag-specialize in cardiology, sub-specialize in electrophysiology, and then in pacemaker insertion. No? Tapos pagpunta sa probinsya, hindi pala niya magamit. So ako ganon, I trained in cardiology. I'm now trying to practice general internal medicine. But I'm still not an adequate primary care provider. So there are existing people there who want to help. Barangay health workers feel undertrained. So we just want to be able to supplement them so that we can duplicate the success we had with family physicians in UP. No? Bakit napakamura ba ng nagastos? Kasi they don't prescribe or do tests indiscriminately. Piling-pili. Pag tinignan namin, piling-pili ang mga ginagawa to what and limited to what is essential. No? Yun isang problem with specialty care. Pagka 5 ang doktor mo, they cannot prioritize. Kasi for the nephrologist, priority yung nephrology. For the cardiologist, priority yung cardiology. So lahat yun priority. But if you have a captain of the ship, they can decide, ito lang yung budget mo, ito na lang ang inumin mo. No? And then, pag umaling ka na dyan, we can go to the other drugs later.
Sorry. Addendum lang. I'm just concerned with the implementation of this primary care because it will involve health workers and health workers under the local government unit. And anything na gagawin nila, it should be with consent of our local chief executive. I'm just wondering what will be the coordination.
So, with one of the main criteria for choosing Bulusan and Samar for rural area and Bulusan for the GIDA area is the LGU support. No? Tama kayo, napaka-importante nito eh. Kasi they own the healthcare delivery system. They run it. So we have their full cooperation and we are overwhelmed by the support being shown. in Bulusan and in Samal.
To add to that, going back to the SDN concept, the fact that the SDN concept is much bigger, it does include other stakeholders like the LGU. So that's the importance, I think, of the overall global leadership here. Para they're all on board. When it comes to the health services in an SDN, are we going to be fragmented or are we going to be more coordinated, more continuous, more continuing? So, siguro I can announce already the groupings. So to keep it simple, because luckily the 4 facilitators are seated in different tables so far anyway. So the first, I'll go by 2 tables vertically with Dr. Stura taking care of the first core function, which is first contact. So that table and the table behind. The 3 tables near the door and on this end, the third table, I leave it to you to decide which of these columns to join. The second group I will be facilitating. That mine is the comprehensive care. So this table and that table. And then for the third group, I think Dr. Inday for pictures. So
per table daw. Whatever table you sat.
So the third group would be under Dr. Lorenzo, this table and that table. That's coordinated care of these 2 tables. And then Doc Inday, your table and the table behind you is the 4th one, continuing care. So again, we will be going for lunch now, and we will have to be going to a different part of the hotel. So at least you know your table mates when you come up. It's now 12.
Do you guys mind taking lunch for 30 minutes and then so we can come back and start? So, yeah, and then we're having lunch somewhere else. So lunch will be served downstairs.
Downstairs at ground floor.
Downstairs, ground floor, what room?
Hello po. We're going to have our lunch buffet at the Latitude at the ground floor. I think they should staff, just give it to them. Thank you.
We eat first and then everything else is back. Sa buffet din.
Approved without thinking. Hi, hello. Nice to see
So we can give the full paper of
Save kitang seat na.
Maybe we can find
I needed that's my art. But I'll be hunting on
sustainable transport. Pero din naman yung job kasi hindi ko na-support sa sama sa region na kailangan export yung taga-region. Yeah, I'm serving for the ASM na nga. Okay.
Well, so, ito yung... Yeah, so they may as well... Pwede rin naman sa training. Kaya lang sa training kasi they're well trained in that.
You're invited here.
You're looking at the primary proponent of that. Kailangan talaga yun. Kailangan talaga. Ang ano ko lang, we're thinking of a 2 or 3 day workshop. It could be, well, yeah, it could be the 5th thing, social deterrent. It could be the, aside from those 4.
Yeah, because...
Ang ano ko lang is how much, kasi it's not as easy as it looks. Yung managing that is not simple. And have, you know, funds for a few days of workshop. And if adding that will crowd out primary care. Ikaw kaya ang hire natin. Okay, sa bagay si Ichi. Lecture. What about putting one a 2-hour workshop na meron kang 30 minutes lecture and 1 and a half hour. Kasi sayang yung opportunity, yun ang point niya. And it improves them.
So easy.
English to? Americano to?
So it is basic. And it is basic for them.
I get it.
Kasi they come from you really don't madali pasok yan eh.
Madali. Hindi siya mahaba.
Kasi when we...
Anong level yan, PH daw? Hindi siguro to, pwedeng sabay-sabay sila. That would be the session, lahat sila.
Isasama nila yan eh. Kasi sila nakatira. They come from...
Isa pong problem sa concept na yun, yung primary health care. One of the key elements of it is it is not the purview of the healthcare sector. It's all of society, it's all of government. And then here we are teaching the healthcare providers about primary health care, when in fact it should be a session with the builders of that community. So baka in that session we need to invite everyone.
Definitely. Kasi
Hindi lang.
Pero alam mo, kailangan alam mo, kailangan sila muna start with it.
Baka pwedeng i-fund ng ng NGO. Ang ganda ng NGO support namin.
At saka isa, if you, pag ginawa mo yan, you bring the actual, the local community right there.
It's a way of
Putting to the side.
No, it's a way of engaging the community.
Very much. Very much. That was my experience. That is the first thing. Teka muna,
saan? Baka nahulog.
May dalawang katabi ko, walang
baka nahulog.
Wala yung akin, hindi ako kakain.
Ayun. Halika, baba na tayo. Let's decide each other.
Diba? At para sa akin, ano yan eh, importante yun. Kaya lang nagbabalik sa ito. When we started this. When I started this, alika na siya.
Dalawa na kakilala.
She invited me to talk sa